That's okay. Good morning, everyone. The first thing I want is a disclaimer because Dr. Tohmeh put this presentation together, asked me to present it, but clearly he did not understand the 5-slide, 5-minute guideline. So I'm going to do my best to rustle through the 12 slides, I believe, that we have. So anyway, we want to talk about our new PTP approach to lateral surgery. So going back in history with Dr. Pimenta's work that started in about 2001 for lateral, 2003 when we started really moving forward with XLIF, which is now widely accepted, highly published, etc. So we all know why we do it, so I'm going to skip that slide. So in the lateral position, if you want to do your entire procedure with your posterior work, there's always those challenges. Can't get around the table. If you're trying to do a direct decompression, obviously a lot more labor intensive in that position. So how can we better maximize that? So for the Transpsoas approach, we can avoid flip time because we're in the same position from the beginning. When we use the Jackson table, we get that increased lordosis just by the positioning of the patient. So again, trying to avoid the psoas muscle and have safer access for our approaches. We found that putting the patients in a prone position with a bit of hip flexion is moving those elements so that we have an even safer plane. We're doing obviously continuous monitoring during surgery. In this particular, we're using SafeOp and the AlphaTech system. So how do we get them there? We put them on the Jackson table. Their abdomen hangs freely. The lordosis is created by that position. We have some lateral bolsters that are at the side and at the flank of the patient so that when we plane the table, the patient is stabilized. It involves a lot of tape at this point. So if anyone owns stock in the tape company, we're doing all we can for you. We use the AlphaTech retractor, and then there's a posterior shim. There are screw shims that we use into each vertebral body, which gives us great stabilization, and then the ALL retractor as needed. So once we obtain our safe exposure and we're sure we're in the right place, we simply plane the table so that the patient is essentially in the lateral position. Then we do our lateral work just like we always have. And then once that is completed and we have the cage in place, and then we usually close the muscle layers of that incision, but not the skin. And then we put the table back in the neutral position and we do our posterior work. So we've done about 100 cases total. There are about 20 surgeons doing this. Dr. Tohmeh and I did a 3-level. We were very lucky to have Dr. Pimenta with us there for the first procedure that we did. So the other thing that's really nice about this procedure is if you have to do hardware revisions, or then you can do your laminectomies, all of those things can be done in the posterior position, but you haven't had to take the time to flip the patient, re-sterilize everything, and re-drape. So it really has improved efficiency in the operating room. Time is money, as we all know. The patient's under less anesthesia time, and the results are fairly fantastic. We've not had any significant nerve injuries, and the patients really do very, very well. So this is a case that we did. It's got a lot of pictures in here. There we go. So that was the final result after having had done the revision for adjacent segment disease. And I think she had a non-union also. So we're very excited about it. It's highly efficient, and the patients are doing very well. That's better. Thank you.